Welcome back to another episode of Single Payer Radio. Single Payer Radio is a project of Kentuckians for Single Payer Healthcare. We are an affiliate of Physicians for a National Health Program, the Kentucky chapter, and we're proud to be a community partner here at Forward Radio. The views and opinions expressed on Single Payer Radio are those of the speakers and not the stations. And if you have comments about the show or would like to share your healthcare story, please send a note to Kay Tello. She's the chairperson over here at Kentuckians for Single Payer Healthcare. Kay's email is nursenpo@aol.com. That's nursenpo@aol.com. And if you'd like to learn more about Kentuckians for Single Health Care, then Single Payer Healthcare, you can go to kyhealthcare.org. And we're coming to you here on Forward Radio, WFMP LP, and we're coming to you because our listeners are our supporters. That's why we're on the air. We're an all-volunteer radio station, and we invite you to become part of the Forward Radio family. You can go to forwardradio.org. Please join us. And joining us back in the studio are Doctors Mike Flynn and Dr. Eugene Shively. And this morning, what are we going to be talking about, guys? Pharmaceuticals?
Talk about the pharmaceutical industry in this country. Before we do that, though, let me do the usual disclaimer indicating that the comments that I am making represent my personal views and do not represent the views of the Department of Surgery or the University of Louisville that had been my employer for about the last 30 years.
I want to express the same thing. My views of that are my own. They don't represent the Department of Surgery nor Taylor Regional Hospital. I'd also like to say that some of these numbers are quite variable and things change. They almost change on a daily basis. For example, the drug industry leaders were supposed to meet at the White House today to discuss with President Trump some ideas of how to reduce drug costs, but they decided not to come. So the drug industry is costing us a huge amount of money. It represents approximately twice as much as any other wealthy country in the world. The United States spends twice as much on drugs as any other country, and we're responsible for half of the drug bill of the entire world. So that's significant. And we're going to talk a little bit about why it costs so much in America.
Well, Trump took off to go to a rally somewhere, didn't he? Was that the reason these guys didn't show up? Have a meeting in there in an empty room?
Well, I don't think so. I think that the drug industry is the one who decided not to show up.
Well, what we thought we would do this morning is to look at the pharmaceutical industry, just in the interest of time, in three components: the regulatory environment, the high cost of drugs, and the opioid crisis. So let me just begin with a couple of sort of broad statements about the regulatory environment. So first of all, there is no system in the U.S. to manage drug prices. Medicare, and I say this again, just one of those head scratchers. Medicare, which is the largest purchaser of drugs in the world, is prevented by federal law from negotiating with the drug companies. And we'll talk about that in a little bit later in relation to the Part D issues. The FDA, the Federal Drug Administration, has no regulatory authority to do any comparative reviews of medications. In Canada, Health Ministry has a drug review board that reviews various drugs for their effectiveness, their appropriateness to be used in that country, and the price. And as we learned last time when we had Dr. Kraus, that in Germany the company or the government negotiates with the drug companies, or I guess it was the health insurance companies in Germany. Is that correct, Gene? They do the negotiating with the drug companies.
They call it the sickness fund, but I think each state has their own sickness fund.
Yeah. Okay, one more thing about Medicare, and one again, as I mentioned, this 60 million members, the largest drug purchaser in the world, and is unable to negotiate with the drug companies. And this was the result of the Medicare Modernization Act in 2003. In which this Part D plan was put together to manage drug issues for Medicare, and they put a step called pharmacy benefit managers in charge of this negotiation, and we thought we could talk a little bit about that because, at least in my opinion, this is another head scratcher. But what exactly these folks are doing? You had some thoughts about Gene, and you'd mentioned.
Well, I think it was all political. The Congress said that drug companies could charge anything they wanted, that Medicare had no role in what the actual price would be. Now, Medicare couldn't go so far over what they charged, but there was a limit on that, and it was strictly political.
Now, these represent for-profit companies that take a cut out of this process, basically at the expense of the Medicare beneficiary. So they've got their hand in the cookie jar. They represent a middleman between a drug company and a Medicare. Now, I agree with you. Whatever political process was going on there, this got into the law. One wonders why is it necessary to have for these people to exist. Now, you could hire somebody who would work as a member of the CMS, be on a salary, whose job would be to negotiate with the drug companies in the same way that the VA has employees of the VA who are negotiating the drug prices with the drug companies. And as you mentioned earlier, the United States, we pay 3 to 4 times more than countries that negotiate directly with the drug companies.
Well, let me just tell a couple of personal stories, and then the reason I got interested in this is because I would ask a pharmacist, why does this drug cost so much? And I must have asked 30 or 40 pharmacists that, and they claimed they didn't know. And I think they were telling the truth. Well, a little over a year ago, I switched from insurance with the hospital to Medicare. And so I had the chief pharmacist at our hospital look into this, which would cost me more to stay at the hospital or to go to a private pharmacy. And he looked at all the drugs I was on, and it took him about 2 days to figure this out. And he finally figured out that I was going to save about $1,000 to go to an outside private pharmacy. Well, then I'm on a drug called oxycarbenzapine, which is a drug for trigeminal neuralgia. And so the first time I went to buy this drug at the private pharmacy, it was $137. So I called the hospital pharmacy and I said, how much you charge for it? And they said, $37. That's without insurance. And I said, how can that be? Well, I called the private pharmacy back and they said, oh, by the way, we've been looking on the computer and we can get it to you for $20. I said, well, how can you do that? They said, well, it's listed here, United Healthcare. I said, you talking about the insurance company? No, I don't know what this is, but you can get it for $20. I said, well, I'll take it.
No, this is. Yeah, let me give you another example. This is a report from the Kentucky Cabinet for Health and Family Services in 2019. And this has to do with the pharmacy benefit manager issue. There are two pharmacy benefit manager for-profit companies in Kentucky that manage the Medicaid prescriptions. And in 2018, they made $123 million in profit. So like $123 million in profit. This is Medicaid. This is the government insurance for people who are not over 65, who are basically uninsured and need this. And the way this works is they pay the pharmacy a lower price to fill a prescription, and then they charge Medicaid a higher price for the same prescription, and they keep it. And again, when you're scratching your head trying to figure out how you would figure out ways to provide good health care for people who are uninsured or underinsured, where did these guys come from? And I agree, you're absolutely right. Whatever the circumstances were back in 2003, this was inserted there as a political benefit for somebody.
Supposedly, the pharmacy benefit managers was for the purpose of saving money. And in the last 2 or 3 days, I've been trying to figure out exactly how they work. It's very complicated. It's not transparent. And there are about 3 pharmacy benefit managers that control the cost of most drugs. Now, for example, they will negotiate with a pharmaceutical company, and then they will take that drug, and then they negotiate with several different companies, like insurance companies or pharmacies. And there will be a different price at Kroger or Walgreens or CVS. And you can actually get on the internet and look at different prices, and there's such a phenomenal difference. And what they're doing is they're negotiating different prices. Now, the drug company also will give the pharmacy benefit manager a rebate. About a fourth of the drugs in the United States that are sold, you can actually go without insurance, buy the drug from the pharmacist for cash without your insurance, and it's cheaper than if you have your insurance. For example, if you go buy the particular drug and you use your insurance, you have to pay your copay. Well, the copay could be more than what the cost of the drug is. Yet the pharmacy benefit manager will get a rebate. They keep all that money, and you're paying your insurance, and then you're paying your copay. It's very, very complicated. You can go at a company called GoodRx, and there are lots of these companies now, and they negotiate with different pharmacies, and they get discounts. Exactly how they do that, I don't know. But it's really interesting if you have the time to look at the different costs of different drugs from different pharmacies. Don't try to figure it out because it's too complicated and the truth is not out there.
Complicated, huh? That seems like a foreign word with our healthcare system. And with the pharmacy benefit manager, it's not only, it seems like this issue came up a couple years ago, that it's not only the cost of the drug, but also there were independent pharmacies who were not in on this, and that creates an impact for, locally owned and operated pharmacies.
Yes, the big pharmaceutical companies like CVS, they negotiate a price. And then the pharmacy benefit manager goes back to the drug company, gets a rebate. So the pharmacy benefit company is profiting on both ends. And nobody really knows how much they're paying. Actually, they have contracts that you're not supposed to reveal this information. There's a disclaimer in there that if the patient asks how much, the pharmacist is supposed to tell them. But unless you ask, they're not going to tell you. And the pharmacist may not know how much. A pharmacist that works for Kroger probably does not know how much Kroger paid for this drug. And he for sure doesn't know how much rebate the pharmacy benefit manager got from the drug company.
Now, losers here are the patient or the Medicare recipient or the Medicaid recipient or just somebody who happens to have private health insurance, because they're all getting jiggled around by this system. And, this is probably is a good example of the kind of fundamental basic issue that we started talking about in the very beginning, how healthcare in this country, instead of being considered an essential public service, and whether you call it a government responsibility or some other authority responsibility, it is considered a commodity and is exploited by these for-profit entities. And this confusing, this roundabout, almost insane process of having somebody between Medicare, Medicaid, and whatever other entity involved in the production of drugs and prescriptions, making a profit by sort of buying low and selling high. It's clearly just another example of the sort of things that somebody needs to address at some point if we're going to have a healthcare system that makes any sense in terms of benefiting our citizens.
Well, the Trump administration, of course, everything's political, but apparently they've gotten wind that a lot of people are concerned about this. And Trump recently has initiated some executive orders, one of which is that qualified health centers can pass on discounts for insulin and EpiPen. And then the other thing that his executive order is, and I didn't know this was, that the president could do this, is that he's going to allow a pharmacist to buy drugs directly from Canada and other countries where the drugs are much cheaper. This is one of the things that the pharmaceutical industry is upset about, because obviously they will lose a lot of money. And then there's also an executive order that rebates will have to be passed on to the consumer. How this is going to work, I don't know. Obviously, I think a lot of it will depend upon what happens in the November election.
Yeah, this all gets so confusing and so difficult, especially for older people who really, take it in the neck. Let me just make a comment about how at least one other country sort of deals with the issue of drug management, and then maybe we can kind of move on to some specifics about the high cost of drugs in this country. I talked a little bit about Canada and Germany. Now, Australia, again, country very similar to ours in many ways. A new drug is brought into the marketplace, then an application is made to a Pharmaceutical Benefits Advisory Committee. Now, this is a committee that's got a bunch of professional people on it who know a lot about drugs. It's not a bunch of CEOs of the drug companies. And they need to prove to this group that this drug is more effective than the others on the market. And the goal here is not to have 5 drugs all doing the same thing, which is what goes on in this country a lot. And then that committee makes a recommendation to the healthcare system either to buy the drug or not, because their healthcare system is kind of like Germany, and where they control the access to drugs by a regulatory body, and they suggest a price. So many other countries have done a better job than we have in managing these issues. I'm sort of out of steam here with pharmacy benefit managers, Gene. You got anything else you want to say about them before we move on to the cost of drugs in this country and other countries?
Well, I'll add one other thing is pharmacy, if we could eliminate pharmacy benefit managers, we would probably save about $150 billion.
Yeah.
That's a lot of money.
Yeah. And there's so many examples of how this exploitation of the system by the for-profit entities exists.
Yeah, and it's not just patients, but it's also taxpayers.
Yeah.
That are getting the short end of the stick on this.
Well,
as
they're supporting Medicare and Medicaid.
Exactly.
And this groups in there have got their fingers in the pie. And I mean, literally, they buy low and sell high, which I think if you can get away with it when you're selling cars or running shoes or something like that, I think makes a lot of sense. But when you're dealing with health care and the access to a 65-year-old person to insulin, then that becomes an issue of morality, not just a matter of profit.
The other thing that pharmaceutical companies are doing now that they used to not do is that they're direct-to-consumer advertising. And direct-to-consumer advertising cost us about $30 billion approximately. About 86% of that advertising is from hospitals and pharmaceuticals, and about 2/3 of that comes from direct advertising to consumers, and this creates a real problem. They're advertising some very complicated drugs, some drugs that are actually dangerous, and sometimes I see an advertisement and I'll get out my iPhone and look it up. It's a drug I'd never heard of, and they're telling patients that they need to take this, and patients frequently go to their doctor and say, why don't you try this drug? We are the only country in the world that does this kind of behavior modification, and it costs us a huge amount of money.
And try to watch the news in the evening, whether it's CNN, MSNBC, or Fox News. You get about 5 minutes of news and then 5 minutes of an annoying advertisement about Eliquis or some constipation medicine that's magical or some other thing like that. I mean, yeah. Well, listen, let's talk a little bit about how much drug cost in this country compared to other countries. I've got 3 examples right here. Nexium, which the monthly equivalent cost in this country is $250 for an equivalent amount of the same drug in the Netherlands is $23. And Humira, again, an equivalent monthly dosage in the U.S. is over $2,000. It's half that, $1,100 in England, and about a quarter of that, $800 in Switzerland. One more example is Gleevec, which is an anti-cancer drug, costs over $6,000 in this country, and this is the monthly dosage. England, it's a third of that, it's $2,600, and in Canada, it's a little over $1,100. Huge differences and there are more of these we can talk about, but any comments about that, Gene? I'm going to talk about a caravan to Canada in a minute.
Well, I've got some data on the per capita spending of pharmaceuticals in the United States. We spend approximately $1,400 per capita. In Germany, it's half that, 667. Netherlands, 465, and in Sweden, 566. So, we as consumers and for pharmaceuticals in America spend approximately twice as much as most other wealthy countries.
Yes. Again, the caravan to Canada. This is back in May of 2019, and it's the same issue of how much drugs cost, and the access or the lack of access to these drugs by people who may have some financial limitations. So this caravan of about 20 cars went from Minneapolis to London, Ontario, purchased insulin, which is not a recreational drug. I mean, this is a serious life sustaining medication. The average insulin cost in the USA from 2012 went from $2,800 to $5,700. That's almost that's at least a 2.5 times increase in a matter of 4 years. So that's a big hit for folks that have limited resources. Vial of insulin in the U.S. costs $320. In Canada, it costs $30. So this caravan of people, of 20 cars that went up to London, Ontario, saved an average of $3,000 on purchasing insulin in Canada, as opposed to having to go through the high cost of drugs here for the reasons that we've been discussing. Now,
go ahead.
Well, I've got some other examples of the the insane differences between the cost of drugs in Canada and here. So EpiPen, this is the epinephrine gadget that's the injection for anaphylaxis. $290 in Canada, $620 in the U.S. Crestor, to lower your cholesterol, $160. This is an average comparative doses. $160 in the U.S. Canada, $730 in the U.S. I'm not going to go through all of these. Nexium for heartburn, we already talked about that. That's $214 here, $736 in Canada. Now, Synthroid, and this is not a drug that was just recently developed after 10 years of research. It's been around since the flood. $50 in the U.S. It's twice as, and just this. I'll talk about a generic, and then the last one on here is Advair, asthma, and COPD. $212 in the U.S. in Canada, and $980 in Canada. So it's three to four times more expensive in this country to purchase drugs than it is to go to Canada, where we mentioned earlier, the drugs. There's a regulatory body that controls the cost of drugs in that country, and in many others.
Another example is erythromycin, which is a drug that's been around at least since the late 40s or early 50s. $600 in this country. And doxycycline, which used to be on the $4 list, is now $60 or $70 for an average prescription. And doxycycline is kind of important for people who have resistant organism like resistant staphylococcus, MRSA, and we have to pay a huge amount of money, and it used to be very cheap.
Now, doesn't a lot of the research that goes into the development of these drugs, isn't that our government does a lot of that research, doesn't it? So it seems like that could save on some of the cost.
Well, actually, we talked about this a little bit when Dr. Krause was here. I've been on the IRB at the University of Louisville about 15 years. And 15 years ago when I started, there was a pretty good percentage of research which was government funded from independent study groups. The Children's Oncology Group, COG, or RTOG, the Radiation Oncology group. These were all independent bodies that are made up of usually medical professionals, pharmacists, people who just want to find an answer. And over that period of 15 years, the number of studies that are protocols that are written by these government-funded, NIH-funded study groups has decreased. And the number of protocols for new drugs that we see now are very much in a majority from the pharmaceutical industry. So they're industry-sponsored. It's interesting how in a short period of time, 15 years, this process has changed as the national government-sponsored research has decreased and industry-sponsored research has increased. And one of the interesting effects of that on an institutional review board, when you review a protocol, the purpose of reviewing it is to make sure that whoever decides to be included in the study knows why they're having the study, what the potential benefits might be, if there are any, and what the risks might be. And it's a fairly complicated process when you review one of these protocols. But what I've noticed is if you review an industry protocol that's written by the drug company or whatever other industry company is submitting the protocol, because some of these are developments from different types of companies. In subtle ways, they tend to sort of increase the benefits and decrease the risks. And so, as a review board, we often have the responsibility of making them rewrite the protocols or rewrite the informed consent so that the risks and the benefits represent more of a reality and then the sort of wishful thinking that often comes up in these. So, Mark, to answer your question, there's less research going on that is funded independently by the government than there was 15 years ago.
I think, though, we ought to give the drug companies some credit. I mean, they've done some remarkable things. For example, the virus, I would have never thought that patients with AIDS in the 80s would now be living a normal life expectancy. Some of the new cancer drugs are just phenomenal. Patients with metastatic melanoma, patients with metastatic lung cancer, we've got some new drugs that these patients are disease-free. Jimmy Carter's an example of melanoma, where he had metastatic disease, was given one of these new drugs, and now he's disease-free. So they are doing some great things.
Oh, they are. But again, I think, one of the things I hope we can get to in another program is what we really do well in this country. And what we do well in this country is and Dr. Krause alluded to that when she was on, is we do investigate and develop new drugs, but we do this in a way that is safe, and it's regulated. And it's regulated by the FDA and Health and Human Services, and the institutional review boards all over the country are in control of how this process works. Now, if that ever goes away, then Katie, bar the door, because who knows what's going to happen. But I think to their credit, the drug companies do a good job as long as they're in a well coordinated and well-regulated environment. And just from a sort of philosophical standpoint, I think you can say the same thing about capitalism. Capitalism is a good system as long as capitalism is regulated. And, I mean, that's the way it was in this country from about the 40s got to the 60s to the 70s, and then the world started to change.
Yeah, that's a good example, regulation of the banking industry and Wall Street.
Well, and I guess I had a question about the relationship between FDA and industry funding. Does the industry fund, do they supply funding to the FDA? The industry, FDA is supposed to regulate? I mean, isn't there some kind of connection between those two?
I don't know the answer to that. Do you, Gene?
No, I don't think there is.
Okay.
The FDA is strictly regulation, and they go through a very complicated process to make sure the drug's safe and that it's indicated. They've become overwhelmed, though. For example, when I graduated medical school in 1970, there were probably about 200 to 300 drugs that were worthwhile. There's now that many drugs that are coming out who are a year that are worthwhile. It's impossible to keep up with them.
But the FDA is limited in doing just what you said, the indications and the safety and the effectiveness, which is important. The cost of drugs, which is one of the issues that we're talking about here, is not regulated by the FDA or anyone else, which are issues that are regulated and controlled in most other first world developed countries.
I would just say to our listeners that you're listening to Single Payer Radio here on WFMP LP Forward Radio. We've got Dr. Mike Flynn and Dr. Gene Shively talking about the pharmaceutical industry.
Now, let's talk a little bit about two things: drug company profits and marketing, and something that Mark alluded to a little bit earlier about the cost of research and the supposed justification by the pharmaceutical industry that the high cost of drugs in this country are essentially underwriting the development of new drugs. which is not true, but it sounds good. So I've got some numbers from a JAMA, Journal of the American Medical Association. This was a 2000 to 2018 profits from the 35 top pharmaceutical companies in this country. So their combined revenue, $11.5 trillion. Now, I mean, really, these are astronomical numbers, and the gross profits are $8.6 trillion. They make more money than the budget of some, of many middle-sized countries. A huge amount of money is going into these companies. And another something you referred to earlier, Gene, was the direct-to-consumer marketing, which is a huge issue. And this is from Health News in 2019. The annual health care marketing was drug companies, $17 billion in 1997. By 2016, it had increased to $30 billion. And the direct-to-consumer marketing in 1997 was $2 billion, and it increased to $9 billion. So they've recognized the value of being able to talk directly to whoever happens to be sitting in front of the television set to sell drugs.
And we're the only country in the world, except for New Zealand, that is allowed to market drugs to the public. And now this doesn't count the amount of money they spend on marketing to providers and also paying providers to give lectures and those kind of things. I remember when I first went into practice, the representatives from a drug company would come by. They were usually pharmacists. They would give you some good information. They would give you sample drugs that you could give the people who couldn't afford the drugs. And I never felt pressured that I had to buy this drug. I felt that they were giving me good information. Now it's different. Almost all the drug reps have degrees in marketing, and it's just totally different. I feel like they're trying to seduce you rather than give you good information.
Yeah, I really never actually dealt with much of that. I just didn't want to do it. I was uncomfortable. They would come in the office and they would bring a bunch of sandwiches in and do things like that. I ran the VA tumor conference for about 10 years. And for a period of time, this was at 7 o'clock on a Tuesday morning, we had a drug representative would come in. I'd let them put a table up in the back of the room, and they'd have some orange juice and coffee and donuts and things like that. And they could put their products out. I never let them talk. They didn't get the podium for any reason. And, the people that came in, they could be there early and they could stay afterward, and residents and the medical students and the staff that went. And then the VA, I don't know, after about 4 or 5 years, they decided that the VA then had a policy that drug reps weren't going to be there anymore, and they were gone. And that was really the only. I never went on one of these tours. They take you on a boat, down to the Caribbean, and you'd have to listen to these things. No, really. I mean, out in Colorado, you'd go skiing. People would go out to Colorado. They'd be up there at 7 o'clock in the morning from about 7 to 9 or 10. and they all be sitting around with their ski boots and listening to somebody do something, and then about as soon as the thing was over, you could hear all the boots getting clapped, and everybody clumped out the door and went to the slope. So there was a lot of that going on. If we have enough time to get into some of the OxyContin thing with the drug, the opioid crisis, there's some interesting thoughts I've got about that there.
Well, let me just say, as a patient, and I don't get into the doctor, but hopefully it continues once a year. I'm sitting there waiting to be called back, and I see an army of suits going back, and it just seems like it never stops sometimes.
Yeah, I refuse to do that. I just didn't have any. The only time I had one of those representatives was a guy showed up with a special gamma probe. You know, we used to do this parathyroid surgery, and you would give them a radioisotope, which would concentrate in the parathyroid. This is a gland in the neck that controls the calcium metabolism. And when it becomes overactive, and 95% of the time it's one gland, you've got 4 of them. If you can find that one gland, you can take it out doing a relatively small, quick operation with a small incision. And so the way to do this was to give the radioisotope, which is a visual. It concentrates in the gland, and you actually can see where it is. And this guy was, and there's a probe that measures the radiation that you move around on the neck. But this guy came in with one of those things that it didn't work very well. I mean, it's just a waste of time. Anyhow, we're getting off topic here. Let me. I'm going to talk a little bit about this issue of the high cost of drugs in this country being necessary to support or underwrite the development of new drugs. And as soon as the fire department gets by, I'll talk about that. Okay. So there's a book written by a couple of guys named David and Paul Belk. It's called The Great American Healthcare Scam. And basically it deals with the high cost of drugs necessary for the development, new drug development. So in this book, they've done a couple of things which were interesting. Number one, they reviewed the Pfizer annual financial report. So on page 17, they've got, this is 2011, the total revenue of Pfizer in 2011 was $17 billion, which is, it's not bad. They spent $9 billion on research and development, which is 14% of their total revenue. They spent $19 billion, over twice as much, on marketing. And they had a net income, a profit, of $10 billion. So these guys are not going broke, and they're not using huge amounts of revenue to underwrite the development of new drugs. And then they went on a little further on. They reviewed the from 2011 to 2018 the combined profits of 13 major drug companies, comparing the profits versus the cost of research versus the cost of marketing. Again, this is not just one company at 1 year. This is multiple companies over multiple years. So it averaged out that about 17% of their total revenue was spent on the development and research of new drugs. 27%, little less than twice that, was spent on marketing. 6% in taxes, which I felt was an awful example of, I don't know what your tax burden was, but when I was working, I was paying 35 to 40, 48% taxes. These people are paying 6%, and they're 19% profits. I mean, it doesn't get much better than that. And so this whole idea of the high cost of drugs in this company, I don't know, I keep saying that, in this country, is necessary in order to justify or underwrite the development of new drugs simply isn't true. And, a lot of people believe this, including my brother-in-law, who we may have on here at one point later down the road.
Well, I used to believe it myself.
Yeah.
Until I started reading about it.
Yeah.
There's a new edition to that book.
Okay, well, I haven't got to that yet.
Well, you talk about corporate welfare reform needed.
Yes.
I mean, good Lord.
I mean, 6% taxes. And these people are making billions, multi-billions of dollars a year, and they're paying 6% tax.
And what year was that?
Let me see here. Well, this was 7 years from 2011 to 2018, 13 drug companies. So this was not one drug company for 1 year. So this represents the kind of corporate welfare that exists when you think about some people like us who. I don't consider us multimillionaires. I think we're both comfortable. But I wasn't working. I wasn't in some sort of independent practice. I worked with the university. I was paying 38% of taxes. These guys are paying 6%.
Yeah. Yeah.
Okay. Well, let's see. We're getting short on time. I'm trying to think how best way to get into the opioid crisis. Let's just do this quickly. There were 3 waves. Okay, there was the opioid wave. Then there was the I can't see this. Let's go straight to the OxyContin issue. Basically, OxyContin is a morphine in a pill. Okay, you can crush it. If you're an addict, you can either inhale it or swallow it. You get a quick, intense high. And this was marketed by Purdue Pharma, which is a company owned by the Sackler family, which is offshored billions of dollars to keep them from being vulnerable to lawsuits. They did aggressive marketing in the, quote, non-malignant pain market, unquote. And they did all of the things that, Gene, we've talked about earlier, but they had conferences, they had speaker training, they did these in resorts in Florida, California. They focused on primary care physicians, and their sales, OxyContin sales, went from $49 million in 1996 to over $1.1 billion in 2000. And one of the issues that they were focused on as they were marketing OxyContin was that they were minimizing the risk of addiction. And the people that were going to these speaker bureaus and the sales reps were all going out to the communities and telling people the risk of addiction was very low. And we know the risk of addiction can be as high as 50% today.
It may even be higher than that.
Yeah.
Well, we've got a real problem with the opioid addiction, and it's not going to be easy to solve.
Yeah.
There are other factors involved. In the 90s, based on some opinion of one doctor, which was really not a paper, so they came up with the idea that pain is a vital sign. And you remember when we had signs all over the hospital, particularly in the ER, how much pain are you having? And it was a requirement that we emphasize that. In so doing that, we gave too many narcotics. I'll remember making rounds, particularly one nurse. In the morning, she always asked, "How much pain are you having?" on a scale of 1 to 10. We have this little smiley face symbol, and I'd see guys sitting there eating breakfast and saying, "Oh, my pain is 8." Well, I don't think you can have a pain of 8 and eat breakfast. So, and then there were other factors. Most doctors should have known that not to give that much narcotics. I'm not sure why we got trapped into that.
Well, let me give you a couple more quick numbers, and I know we're getting short on time. So between 1999 and 2017, 700,000 drug overdose deaths, and 400,000 of those were opioid overdoses. And a lot of lawsuits, Purdue Pharma, Johnson & Johnson, 24 states, and Washington, D.C. The legal profession has a term, res ipsa loquitur, which is Latin for the thing speaks for itself. And basically what that means, that whatever is going on here, whether it's a crime or some event, is so obvious that it doesn't require a bunch of documentation and supporting evidence. And let me quickly run through a quick example of an example of that related to the opioid crisis. 2006 to 2012, pharmaceutical companies shipped 76 billion opioid pills to a single pharmacy in a place called Kermit, West Virginia. Kermit, West Virginia has a population of 400. Now, you would have thought that at some point in time, a little yellow or red light would have gone off in the head of a pharmaceutical executive wondering what those 400 people are doing with 76 billion opioid pills.
Okay, guys, another hour has flown by. Yeah, Mike, it sounds like that pharmacy benefits manager fell down on his job there. Oh, Lord. But let me tell folks that Single Payer Radio can be heard on Mondays at 2 p.m., Tuesdays at 7 a.m., and Wednesdays at 11 a.m. And to get more information about Kentuckians for Single Payer Healthcare, you can go to kyhealthcare.org. Single Payer Radio is now heard weekly. And Dr. Flynn, Dr. Shavley, thanks again. And we'll be back in our listeners' ear next week. Thank you.
Thank you.